Welcome, everybody, to a new installment of the World AIDS Museum and Educational Center's Spotlight Series with your co-host, Andy Ruffner, who is our Director of Education and Programming, and myself, Dr. Raquel Lopes, an acupuncture physician, and the Executive Director for the World AIDS Museum and Educational Center. This week, we are fortunate and lucky enough to have Dr. Marah Lee, who has had a long history in working in HIV in her practice. She did her residency in St. Vincent's in New York City, which was an epicenter of HIV in the early 90s. So welcome, Dr. Lee. Thank you so much for doing this.
Thank you so much for having me. I appreciate the time, and it's always good to kind of share what happened in the bad old days and now that we have the good old days.
Absolutely. So we'll get right to it. Part of what intrigued me having you on is your intersection of HIV in the early 90s and what brought you to doing medicine during that time.
Well, I was a nurse for 12 years. I was living in Iowa and working at an institution for the mentally challenged residents. And one day, one of my residents cut his hand, and I had to take him to the infirmary. Once I got there, the doctor who actually sewed up the patient's hand, I thought I can do a better job of this. So I went to med school.
I love that. I love that. You know, hey, if somebody's got to do it, let me be the person who does it.
That's right. That's right.
And then what led you to working in HIV once you're in medical school? What led you to HIV?
So that's kind of a strange happening. You know, some things happen for a reason, and I'm sure that's what happened to me. I went to med school in Missouri. We talked about HIV for 5 minutes, probably, if I can even remember the 5 minutes. I had some good friends in New York City, and I was going there to visit, actually, my very first flight. So I flew to New York, and they took me around to the whole city, and I decided that that's where I was going to do my residency. So when I started at St. Vincent's,
What year was this?
that was 1989. I started my residency, or my internship, I guess I should say. So I started my internship. Actually, I had never met anyone that I knew was even gay or HIV or, in Missouri. So I was kind of in a culture shock, but I loved every minute of it. So I did internal medicine residency. And during that time, like you said, we were in the epicenter, we were in the village. And so everybody went to St. Vincent's to be diagnosed, unfortunately to die a lot of times. But we had overflow of patients through my whole residency. So I finished my residency in 1992. Then I stayed for another year to be a chief resident there and help train the interns and residents that were coming up behind me. So in 1993, I was done. And I thought I was kind of done with HIV treatment because I'd seen so many of the patients. So I moved to Florida on the West Coast and worked for a group of guys, doctors, who would not allow HIV patients to come into their office in 1993. So as soon as I could, I got out of there and moved to Fort Lauderdale and took over practice here.
Oh, wow. That's amazing. In 1993, we would still have that, but it's not surprising.
No.
And, we were talking offline about treatments for PCP, and I was intrigued that you were that the changes in dealing with it over the years from one thing to the other. Can you talk about some of the things that you saw in the early 90s
90s.
when you were
So
there?
I started my residency in 1989,
Oh,
and then, or my internship, and then you stay on for your residency. So in 1989, um, and the patients were overflowing, and we were seeing a lot of PCP pneumonia in patients. So they were using pentamidine for prophylaxis, keeping people from getting that if they had very low T cells. And most people in that time actually had very low T cells because they hadn't been diagnosed until they went to the hospital. So for St. Vincent's, it was a great place to train because the interns and the residents did all the scut work, basically. So we would have to gown up and take our patients upstairs to a floor that was basically empty and put them in a box and treat them with inhalation pentamidine. So at the end of my residency, I was fortunate to be on a clinical trial with patients in the hospital for PCP prophylaxis with Bactrim or trimethoprim sulfa, which we still use now with patients who have very low T cells to prevent PCP.
Hmm. And is that what got you started on your research career? Because I know I read in your biography for your practice that you have been a principal investigator on a lot of research studies. Was that the beginning of your research career?
It was, and unfortunately that year that I was on the west coast of Florida, I didn't get to do much of anything except see people. So when I moved over here, it just kind of fell in my lap. Since we had such a high volume of HIV positive patients, in fact, that's all my practice was initially, we kind of fell into it. All of the companies that had medications to treat HIV that was not approved yet, basically knocked my door down to get me on the clinical trials, and one led to another, and we did clinical trials with all of the HIV meds. In fact, 3TC or Epivir was on clinical trial when I moved here.
Mm-hmm.
And we tested thalidomide in our guys who were wasting, and we actually were in the clinical trials for many of the drugs. And actually we were principal investigator for the rapid test for HIV
Mm-hmm.
in your jaw. So we were part of that. So over the years, I've done many clinical trials.
Mm-hmm. How did I'm curious, what are your thoughts about that? About how did the patients react to that? I'm assuming you were very successful at enrolling because you kept getting asked. Was it a tough sell, or what were some of the things that came up about working with them around research?
In the 90s, it was basically not a tough sell because unfortunately we were treating people with monotherapy. They would fail that, and then before we had clinical trials or before we had medications, we had nothing. So basically the patient was on the track to not being here anymore.
Mm-hmm.
So in the old days, it was not a hard sell at all.
Mm-hmm.
Patients were, trying to find clinical trials if they run out of options.
Yeah. That's interesting. I worked at the University of Cincinnati, and I was in emergency medicine,
Mm-hmm.
working on prevention and testing, but we had an AIDS clinical trials unit. And I know that in Cincinnati, and I think this was the case in a lot of cities around the country, that having a clinical trials unit was sort of like a crutch for the system, because it got us more resources to be able to help patients, and give patients, you know, if you were on trial, if you could get yourself on a study, you got more care in a way, because they were paying attention to what was going on. And
Yes, absolutely. I mean, the more, you know, more labs, more meds. I mean, oftentimes people would come for clinical trials if they had no insurance. So on a clinical trial, you actually could get the medications, the lab tests, all those things free. And then sometimes the clinical trials would actually pay for your transportation to the office, and you got much closer eye by the doctors for clinical trials.
When the cocktail um, became available in terms of treatment,
Yes.
how did you see your patients change when that became available for people? And were people looking, was everybody looking to be on it, or was there still a little skepticism of is this really going to work?
Yeah, when the first protease inhibitors came out, by then we had figured out that people needed to be on 3 different medications in most instances. And there was a lot of skepticism from patients because they've been on meds. They heard the side effects. They weren't happy about it. And when we added the protease inhibitors, we were adding between 7 and 12 pills to their regimen already that they were on, that was pretty high. So we actually were adding more pills. We were adding more restrictions, like some of the proteases you couldn't eat with. You had to time your food and your pills and your other pills. And so it was very difficult with the first protease inhibitors. That was the cocktail. However, as more protease inhibitors were approved and got a little bit better, sometimes a little bit worse, but over the time period of the 90s, we were still having issues with getting people to agree to even go on those meds.
How was it? I remember, did you deal with the Statlanders pharmacy that was that arose? So for those who aren't familiar with this, because HIV medications in those days, especially the adherence, was so important and people would develop resistance, this mail order pharmacy that specialized in HIV medications, because everybody was getting mail order pharmacy. There was a real growth in the insurance industry, but it was a really interesting thing, the way that they did their practice. And what was your experience in dealing with patients around that, or what did they say about it?
Oh yes, Statlanders was high on the list to get your meds from. And you know, they tried to do information gleaning from the patients by seeing if they'd taken their meds, if they refilled them on, you know, on the right day. So it was kind of the beginning of sometimes we say not so good mail order pharmacies, because we still have them around. And then after Statlanders, we had the local pharmacies that kind of popped up everywhere that was specializing in HIV treatment. Those were much better to deal with than the Statlanders, but you know, we deal with what we have to.
Right. Yeah, I just thought it was incredible the way that they would follow up with people about, you know, you haven't refilled your meds. And this was early on in terms of electronic medical records and those kinds of things. You know, we were still a few years out from that being really widespread, that there was this information sharing. So it was very Big Brother kind of a feel to it.
Right. And that's still kind of going on with some of the mail order pharmacies. But it's not a bad thing.
Right.
And the study that they did that showed that if you were 95% adherent to your regimen, then you were probably going to get to undetectable. Of course, in those days, undetectable was less than 500 copies. Now it's less than 20.
Mhm.
But in the old days, we actually, I still use that every day, or not every day, but a lot of times with patients who have trouble with being adherent to their regimen. So I say, they did a study a long time ago, and if you were on it 3 times a day, you could miss 3 doses and still be okay. Well, now you're on a once a day regimen, and basically you can miss a half a dose and be okay. So you really need to be adherent to your daily regimen no matter what.
Right. Right.
Do you find that patients nowadays are have trouble with adherence? Because the message seems to be the more adherent you are, the healthier you'll be.
Right.
And I was just in a meeting this morning and where they were talking about adherence or staying in care. And there was, to me, some numbers about the different age groups that are staying in care more regularly. And of course, 49 plus or more in care. What I found is the perinatals were in care, but they were lower in care. And I wonder whether there's fatigue for people that prevents them from continuing to be rigid on their regimen.
Mhm.
What do you think about that?
I think there's fatigue, not nearly as much as there was in the earlier days. And the side effects now are so minimal with almost all of the regimens that we can come up with. And we come up with some doozies, so to speak. But in the old days, the fatigue was there or the side effects were there. So patients would take 2 of their 4 pills, but the other 2 made them have diarrhea or were nauseated, so they would skip those. And then at one point we had a refrigerated medication, so the patient would forget the refrigerated one and take the rest of their regimen. So the problem happened with that is they developed resistance. Fatigue now I don't think is so much a problem. I think it's just forgetting that you're even HIV sometimes. The only thing that reminds them is they have to come get their labs done and see the doctor. But oftentimes they get busy and life happens and, they go somewhere and they forget their meds. And so it's just, we have to constantly remind them that it's still very important to take your meds when you're supposed to. And, you may be on more if you don't follow directions now.
Mhm.
That leads me to in your breath, and I guess math. I'm not going to do the math, but 30 plus years of being involved in this field. What would be some of the things that you would see that has changed or has evolved or hasn't at all in this whole time frame?
Well, there's been a lot of things change. Like I said, when I was an intern and resident, we got to do all the scut work. So we did everything, basically. We started IVs, we put NG tubes down, we did all this stuff because the nurses were overwhelmed with other things. So we used to wake up the HIV positive patients every 4 hours or give them their AZT. So AZT was the only medication when I started my internship and residency. So that was bad. And of course, AZT had a lot of side effects. So consequently, people would come in severely anemic and have to get transfusions and, lots of different things. And now, and then through the course of adding the cocktail, as we used to call it, there were multiple side effects. There were multiple times during the day that you have to take your meds. You have to, split up your food and your meds and your water and all this stuff. And I honestly don't know how some people maintain that way of life for a long time, but they did. And the ones that did are still around. Nowadays, it's easy. Basically, it's easy. You can take one pill a day. Side effects are very minimal. And, there's other issues that now we're dealing with because patients are getting older. So not only in the old days would they have had to take their 40 pills a day, but now we have to add blood pressure meds and sugar meds and lots of different things. So the medication thing is a big deal. In the old days, nobody wanted to be tested because they knew it was a death sentence, and oftentimes it was. In the old days, patients would be diagnosed with severe CMV retinitis, so they were blind. It was really not a good time to be HIV positive in the 90s, early 90s. And then as the cocktail came out, then we started to get kind of an improvement on, adherence and improvement on the patient's well-being. But it's changed a lot. I mean, now we have an injectable that we can give to patients who are stable, who have no resistance to certain meds, but we can give them an injection every month. So things have really changed. And of course, we do have PrEP now, which I recommend for anyone who might be exposed to HIV, that improves the inability to contract HIV.
I always say that these 30 minutes are way too short. We gotta do something about that. We just started because I was about to go into aging in HIV.
I know.
But we'll have to save that for
I got
another
more
time.
questions. Yeah.
Yeah. Okay.
But we typically end the show by asking, what do you do on your off time to relax and rejuvenate? What do you do?
Okay. So this is what I do. It's a very expensive hobby, but I have racehorses that use a cart. And I've at one point had 12. Now I just have 4. So, but we race them at Pompano Park. And then I have 5 grandchildren, 2 that I see
Wow.
that are in college. So, and then I like to sew and knit, and
she does it well,
Yeah,
people. She
that's
does it well.
I made masks
Yes,
for everybody in
absolutely.
the office. So yeah.
Well, this has been an enjoyable time, Dr. Lee, and I'm so thankful that you were able to spend some time with us. And hopefully in the future, we will have a different program where we can really delve into the topics that you highlighted, because they too belong in a longer conversation.
Right.
So, thank you for this. And
thank you very much. Thank you for having me. I appreciate it.
And
It's always good to share, because people don't know what it was like back in the 90s. They really don't. So unless somebody says it, then some people forget that HIV is even around, and it's still here.
I just want to say to you that I'm really glad that infirmary doc did a lousy job. I think there's a lot of people living with HIV that really benefited from him motivating you to go on into medicine and
years
get your
ago.
doctorate. Yes.
Thank you. I appreciate that.
Oh, this wraps up our installment of the World AIDS Museum and Educational Centers Spotlight Series with Dr. Marah Lee. Next time we have a special guest, and we'll just keep it a secret for right now, but join us on, I believe it's July 7th at 5 p.m. to
That's right.
see who that will be. Until next time, thank you all for joining us. Thank you, Dr. Lee, for being with us. And we'll see you next time, everybody. Have a great day.
Thank you.
Bye.